Thanks for tuning in, everyone. I'm excited to talk about this topic today, about thoracolumbar spine trauma. It's often kind of unpredictable when it comes in. Every fracture is a little bit different. So I think the principles and understanding how to diagnose and manage the fractures is really important, since there's never always a 100% clear path what to do. So we'll start with a case example. This 27-year-old fall from height about 40 to 50 feet, multiple other lower extremity injuries limiting their exam, and comes in intubated, able to demonstrate distal motor function, but no rectal tone or perianal sensation. On the x-rays here, a few things to notice. Kind of more obvious on the lateral at the L3 segment. There's some height loss and some abnormal contour of the end plates, but largely his lordosis is preserved. And then a subtle finding here is, if you look on the AP, looking at the pedicles in line, you can notice some interpedicular widening, which can be a sign of an injury. And you can sort of make out that the lateral borders of the vertebral bodies are not exactly lined up as well. CT and MRI obtained. On the CT, you can see retropulsion of a fragment into the canal, maybe like 80% height loss with violation of all four cortices of the L3 body. And on the axle, you see how much canal compromise there is there. On the MRI, soft tissue elements, you can see the ligaments being displaced posteriorly, and how severe the stenosis is at the on the thecal sac at that level. So going back to the basics, there's three regions of the spine. In the thoracic spine, tends to have a slightly different anatomy with more rigidity, less motion, smaller canal size, and thus in trauma, the thoracic region tends to have a higher rate of neurologic injury. Especially at the junction between the T and L spine, there's focal area of kyphosis might be even more stressed than other areas because of the transition there. So that's something to realize, that on top of the fracture, this is naturally an area that the spine sees a lot of stress. In the lower spine, the lumbar spine, you have more mobile discs, taller discs. The orientation of the sets is more sagittal, so that also allows for a little bit more flexion. And it's less stable, no rib cage articulations that also hold in place. The epidemiology of the fractures often has to do with poor decisions. Most commonly, actually, occurs in the thoracolumbar junction between T11 and L2. More often in younger people, more often in men. Here's a picture from San Francisco on the right, Golden Gate Bridge. And oftentimes the mechanism is very high energy, so fall from height can be, and motor vehicles account for 65% of these injuries. There can be since it's a high energy mechanism, there's often associated injuries with other long bone, head injury, or skip fractures, as well as abdomen, thoracic injuries. It is notable that some species are able to, their spines are able to bear more weight and built differently. One of those species, I'd say, is Dr. Pompliano with the unbreakable back. The ATLS protocol is your starting point when you see them in the trauma bay. You want to make sure your resuscitation is, gets started to optimize them for surgery, knowing lactate, base deficit, etc. Oftentimes, they might go to ICU if the OR is not ready yet. But trying to get a sense of their mechanism and their neurologic exam before they're intubated or sedated, be extremely helpful. And then emphasizing lateral precautions, making sure everyone in the room understands. And then trying to get a sense of the Asia grading, as well as their rectal tone, and their groin sensation. Lets you know if there's knee sacral sparing, helps you grade on the Asia scale. When you're evaluating the X-rays, overall, you're looking at alignment both segmentally and globally. Looking for kyphosis, any rotation or translation. Talked about the interpedicular distance, and a lot of times the fractures are underdiagnosed based off X-ray. I think nowadays people go to CTs a lot quicker, so diagnosing the fracture on X-ray is probably less common. CT is kind of your standard when you come in. On the MRI, the other things to consider, looking at the discal ligamentous complex as well as the posterior ligamentous complex, and looking for edema in the cord if you're at the thoracic level, any hemorrhage, an epidural hematoma that might need to be decompressed. This can all sort of guide your game plan in the surgery. Classification is a little bit tricky. There's sort of global concepts. The three-column theory, you're separating the spine sort of into thirds, the anterior column, posterior column, and the middle column, and you're separating which zones are violated. That kind of gives you an overall sense of stability as well. If you're only having some injury to the posterior column unilaterally, whether it be TP, pars facet, as long as your anterior middle column are intact, then you may, not necessarily have an unstable segment. But overall, looking for clues on needing to decompress or to stabilize. Other classifications that were described in the past, recognizing unstable bursts, that they can often be gray area, looking for the instability there. This 20 degrees of kyphosis seems to have carried on through literature, although I didn't see anything specifically saying that's a hard cutoff. So these are just rough guidelines that were described, that these are what you could look for if there's any facet subluxation or incomplete deficit that has some kind of obvious bony fragment in the canal. These might be cases that are more likely to benefit from operative intervention. And then also looking at the mechanism of injury to kind of get an idea of where your the force of the mechanism is kind of what you want to counteract with your construct. The AL classification kind of came out more detailing sort of all these fractures in a way that makes it good for research, I think, but clinically less common for people to kind of describe. And it kind of goes from stable to unstable, with the A's being just compression fractures with different variants of where the fractures enter and exit, and then the C's being complete three-column injuries with rotational or translational components, and then B is kind of the in between with distraction components or disruption of the posterior components. The TLEX is probably the most commonly used for guiding treatment, but oftentimes it's exactly 4 points. I think the common situation is you have a burst fracture, which is 1 point, and then possibly disrupted PLC, or if it's disrupted, that's 3 points, that puts you at 4. So either that or having some mild neurologic deficit with compression fracture kind of always puts you sort of in between groups. So kind of comes down to looking at the patient. In terms of guiding the approach, the idea is that looking at the posterior ligamentous complex injury may be helpful in telling you whether or not you have to go from the back or not, but usually you're trying to see where the compressive element is. If it's more so coming from the vertebral body, generally requires an anterior approach. If it's just the posterior instability, then you might be able to just do from the back. Oftentimes you kind of have to think through if both approaches are needed. In general, using this algorithm has been pretty reliable, with some studies showing based on that algorithm, most patients do well in the sense of not getting worsening neurologic status. The modification more recently of the AO spine classification kind of tries to group them again, sort of similar to the old one, but C kind of always being operative, A being minor, non-structural, with incomplete bursts, kind of incomplete bursts, trying to understand the stability. And then there's a distraction, hyperextension, three-column injuries, and often operative as well. Other things to consider if the patient has DISH or rheumatologic conditions or poor bone quality, may kind of make your surgical planning a little bit different to take into consideration as well. So when can you not do surgery is kind of the big question here. In general, compression fracture with intact posterior cortex, intact posterior elements. You can brace the burst fracture. It violates with the posterior cortex with minimal retropulsion and no neurologic deficit. I think that one usually we try to brace. In patients with severe kyphosis at the fragment that worsens when you stand them up, that generally makes you a little bit more likely to operate. No differences in outcomes in surgery versus no surgery in these cases that are sort of non-operative but electively operated on. However, I think you have to think about it as an individual case-by-case basis. The question of whether or not you should brace or not is an interesting one. I think some people definitely do benefit from braces. Here's Ryan with his beautiful smile. But overall, there hasn't been hard evidence that bracing makes a difference one way or another, non-operative or operative. Even followed up to 8 years with looking at kyphosis and outcomes, no difference in x-rays with or without brace, kind of smaller series. And I think from my experience, some people do feel more comfortable with the brace on getting out of bed. Might be a psychological thing, but in theory, it should support the spine and provide some stabilization. In terms of looking at these operative fractures, when there's gross translation and rotation, you kind of need to fix that. There's some studies showing that surgery is helpful in these situations. So when it does come time to do surgery, these are sort of harder indicators. So neurologic deficits, cord compression, fracture, dislocation patterns, severe kyphosis, and other injuries. So polytrauma, if they have to be supine or lateral or prone for a different procedure, say like pylon injuries or something, they will ask you, or even like hip fractures, the ortho will ask spine to stabilize the spine first. So those borderline burst injuries, oftentimes in polytrauma, it makes sense to just perk screw and stabilize. This is another area of controversy. I guess the motto that some people go with is spine equals time, kind of similar play off of the stroke awareness type campaigns. Early literature kind of setting the cutoff at 24 hours, early versus late. Saw a improvement, higher rate of improvement in the early groups of decompression. Certainly waiting can't be better. So that's always something to think about, but balancing, having the overnight team and not having the right OR bed equipment, everything ready, not having fluoro technician. If you don't have these things readily available, it can make sense to sort of get everything ready for first case in the morning, or waiting a little bit longer. But overall, if it were me, I would want to get in sooner, as soon as it's safe. So more recent literature kind of looks at this ultra early concept. I think it's hard for me to interpret sometimes if this is like sort of defensive medicine type studies, because obviously we know the earlier you get to surgery, the shorter your hospital stay is going to be. And also just makes sense that we know very well from orth literature that the longer you're in bed, the more complications you get. So trying to get up and mobilize as soon as it's safe is usually better with surgery if they can um, tolerate it. But there are some studies that say the ultra early, like less than 12 or less than 24 hours, does not have a higher rate of improvement. Again, the patient, depending on what other polytrauma they have, the femoral fractured literature is pretty extensive in flipping back and forth of, damage control versus early total care. But really just making sure the patient's safely resuscitated before you go is generally the conclusion from that body of literature. Waiting too long isn't necessarily good, but going too early before the inflammatory acute phase is resolved can also be increase your risk of complications. So the timing of surgery is still a little bit controversial. I think having the ability to do the surgery within 24 hours of injury is probably desirable for all parties. One other indicator they saw was the intramedullary lesion length. So if there's cord signal changes, the severity of that change kind of determines whether or not you improve. And then overall, I think the literature is like you expect maybe 1 to 2 grades of ASIA improvement based off of your baseline exam. So I think that's all sort of expectations wise. Surgical approaches, how long of a segment you need to fix across has also been studied as well. You kind of want to it be long enough to restore your native alignment and get tension on your ligaments again to help pull the fragments back into their native anatomy. And just from this sort of indirect decompression, you can see reduced in the canal compromise. There's less surgery overall. However, you're compared to spanning, say longer segments, less surgery, but at the same time, maybe less stability. So achieving your goals and knowing what your goals are before you go into surgery helps determine your plan. While you're in there, fusing versus not fusing has kind of been discussed as well. Using bone graft or possibly kyphoplasty, people have done. It's kind of fallen out of favor, I'd say, with the advent of percutaneous fixation. This concept of intermediate screws, meaning putting a screw in at the level of the fracture. It's also been popular, an additional point of fixation. It saves some levels. I think watching Dr. Mundis do some at the adjacent segment fractures, he kind of angles them downwards to try to capture the collapsed segment, usually a little bit of a shorter screw. I think that's something that navigation can be very nice for as well. Get a largest possible screw into the fractured body. It might save you some levels. Otherwise, for really unstable fractures, you're kind of thinking 2 to 3 above, 2 to 3 below, is sort of the traditional way of approaching it. Um, Otherwise, some papers trying to describe the amount of collapse and translation, comminution, just kind of getting an oversense of the instability helps guide whether or not a posterior construct alone is going to be able to um, not fail over time. But I think, again, kind of have to look at it on a case-by-case basis. Going to the front, oftentimes, if you have a lot of vertebral body comminution, may end up requiring some type of corpectomy construct. And then the question of how do you back that up? Do you do front back versus back front? Staging them, looking at how they do, maybe getting a scan between stages to help decide. This is kind of a nuance that I think having people to discuss with is helpful. It's definitely lots of different opinions. I've also seen some cases where they go all anterior and try to put a lateral anterior plate on if it's accessible. But generally, if there's a large retropulse fragment, going through the front is advised. Some people talk about drilling out the pedicle and try to tamp down the anterior fragments from behind. That's a technique. I don't know how reliable it is, but I think everyone has their own experience with what you can get away with. But overall, if you're going front back, you're getting overall more likely to achieve your goals of decompression alignment, but you're perhaps devitalizing some tissue and more incisions, more soft tissue disruption, more ligament takedown may delay the recovery process in its own way. But if it's rotationally or sagittally unstable, that's kind of probably the safest bet to go with. And in looking at these combined approaches, they're generally safe based on the series you look at. Posterior only may have some more collapse over time. What did we do for this guy who came in after the 40-foot fall? We went with the expandable cage in the front, spanning 2 segments above, 2 segments below, preserving the 5-1 junction, doing a partial corpectomy through the front, and stabilizing in the back. So don't know how he did with follow-up, but has a nice restoration of the lordosis there as well. So overall points, takeaways, it's common injury everyone sees on call. Likely high energy with other associated injuries. Want to be especially thoughtful around the thoracolumbar junction, which is a vulnerable area of the spine. Using classification system might help talk about it over the phone, but not necessarily tells you exactly what to do. And then knowing when you can get away with non-operative management, and in terms of surgical indications, though there's no hard evidence, these principles help guide you. Usually, people try to do sort of a posterior decompression and stabilization, but in some cases, the anterior surgery is also necessary. I went through and just looked up some more recent papers on the topic. This is kind of the sort of things that I saw discussed. So how long to go, your trade-offs, just like we said before, people looking at how much adjacent segment there is before with long-term follow-up. With longer constructs, 2 to 3 above or below, you do risk having a longer rigid segment, which increases your chance of adjacent segment breakdown. With shorter segments, you have a less pain and faster recovery, less risk of adjacent segment, but perhaps there is some higher risk of losing your correction angle, depending on how much kyphosis they came in to start with. No good evidence one way or another, so kind of dealer's choice. With percutaneous fixation, do see the typical faster recovery, but no benefit necessarily long term. Um, uh, removal is also kind of a debated topic. Do you go back in and take everything out to allow them to preserve their motion once they've healed? Maybe it's something you consider younger people. I think that the indications for that I'm interested in doesn't seem very clear to me. And then the use of polyaxial tulips kind of is generally preferred to make rod placement a little bit more less futzy in terms of the being able to have some wiggle room with medial lateral rod placement if your heads aren't perfectly lined up. Some people think doing the monoaxial tulips, if you're able to, that's one less point of failure. So one extra area of rigidity that possibly provides better reduction if you're going to try to reduce and use a shorter construct. A monoaxial screw may infer some extra stability in holding your height, keeping your correction. And then lastly, the use of crosslinks, which I know in some ways increases your stiffness and maybe increases the rigidity of the construct, but in certain scenarios, if there's like severe rotational deformity, the construct, the crosslink may be able to provide some extra stability resisting rotation. So just tools in the toolbox to consider. I guess with the my main question I think is with screw removal. I haven't heard anything or read much about um, I think Dr. Akbarni I saw wrote a paper whether or not you go back when they would go back in and take the everything out routinely and whether or not there's fusion or no fusion. Regardless, usually there was enough healing to be stable, I think was in their series. But otherwise, I think whether or not to go back in and subject them to another surgery. In some cases, I've seen one case recently where it was just a normal fusion for degenerative reasons, but they had point tenderness over the tulip head and removal of the instrumentation relieved all their pain. So I guess in some percentage of the population, maybe skinnier people, the screws and rods may benefit from coming out, but I don't know if any of you guys have experience with knowing when you can get away with screw removal after um, fixing the fracture.
It's a newer concept, David, but it's you're conflating two different issues: fixation that's painful and fixation that's just there to stabilize transiently for the fracture to heal, and you haven't fused the spine. So I don't think Beiruz's work was on trauma specifically. That whole concept came about when percutaneous methods became viable, and we could stabilize around a burst fracture and then allow it to heal and not bind up adjacent segments like we had before, fusing 4 or 5 levels just to deal with one fractured level. And I don't think that debate is totally settled. It's a difficult patient population to study, and when you talk about level 1 evidence, incredibly difficult when you're talking about adjacent segment disease because you get 20% follow up on a lot of these trauma series, which would be required to answer those kind of questions. So I would say there's definitely situations that you should think about it. You know, if you've got bony injury and you need to stabilize, but you really only have that singular level, you haven't shredded the ligamentous complex over multiple levels and need to fuse 3 to 5 levels. Something to think about. Where you can get away with fixation for, say, a bony chance fracture or something like that. Long term, there's not a need to have that fixation bind up or tie up other levels of motion. So you don't necessarily have to fuse them.
I guess How often have you seen in clinic someone come back like 2 years after a fractured fixation hurt and having adjacent level problems? Like I haven't seen that situation very much. So I guess it's nice in principle, but
Uh, well, no, but I would think of it a little bit like um, an X fix. I mean, I know it's not sticking out of their skin, but you wouldn't want to leave an X fix across a joint, right? You might put it in transiently, or a bad tibial plateau or something like that to distal femur, something to stabilize. But your intention eventually is to remove it. If you're percutaneously fixing across a fracture site, but tying up otherwise reasonably healthy joints, why would you want to leave that? And we're not letting it stick out of the skin anymore. We used to do that in spine. Now we have the ability to submerge it, like pinning finger joints. But I don't know that you'd want to leave that. So I think you have to pick and choose when it's appropriate. But I think there's still a role for that thought process now that we have the technology to deploy it safely. So it's different than somebody showing up 2 years later, because then obviously that's not part of the plan. They've just shown up. You wouldn't leave it in that long, theoretically, if you're just allowing a fracture to heal. You're thinking in the probably 9 to 12 month range.
I guess maybe like you could get a CT at that point and evaluate how the fracture's healed and if there's
Yeah,
enough mass, maybe that's something to
exactly. You just have to get out of your mind that you're not the fusion thing.
right.
It's a you're treating it differently. If
Hmm.
you fused it, there's little rationale to pull the fixation unless it is painful, as you pointed out. But if you've not intentionally fused something, then you should be intentionally thinking about removing the fixation at some point. And then the other thing that you touched on was how you think about anterior versus posterior constructs. And that debate raged for a long time, and I don't know that it's totally settled, but the whole mindset was around how do you deal with these traumas with a lot of comminution up front, for instance, in a burst, in which case we would typically do three above, two below, or some fairly long posterior construct, which would be stable, but bind up a lot of healthy spine just to get stability. And long term, what does that imply for what is typically a younger population? And we don't know because there's not long term studies on them. Versus doing an anterior construct alone, or versus doing anterior construct with short posterior, rather than what you showed a picture of, which was an anterior plus a long posterior, which is not the intention.
Right.
So if you're thinking, hey, there's a lot of comminution, the Cormick and the load sharing classification came about to help differentiate those patients that would not comply or do well with a short posterior construct. And in those patients, you either need to go long posterior, the sort of standard three above, two below, or use a combination of an anterior construct with a short posterior construct. And Mahar, some of the others, looked at the added contribution of the short intermediate screw, and that certainly helps. But it wasn't totally clear that was sufficient in all of those
Hmm.
cases. So, in some parts of the spine, it doesn't matter quite as much. If you have a T12 fracture and you go two below, three above, you're not tying up a huge amount of spine. But if you have an L2 fracture or an L3 burst fracture and you're going three above, two below, you're tying up the majority of that individual's lumbar spine.
Right.
And then
Right.
it becomes relevant to think, hey, how can I creatively allow for longevity in this person's spine? And no, you didn't cause the fracture, you didn't do the trauma, but you still want to be thinking about the person's longevity, particularly in a realm where we don't know what the long-term viability is, because these patients don't follow up, and we can't study them over 20, 40, 50 years. Anyway, great talk. I mean, it's a big subject. It's one of the things that probably research started on very early because of its commonality and the questions about how to manage these patients, and the questions have changed over time with technology. Anybody else?
Sid, thank you for the great talk.